it's lovely to be here today. I'm so delighted and thrilled that you invited me to talk. And it's such a wonderful day to celebrate such a wonderful resource for the service. And to me, it's a real exemplar of excellent service delivery. You should be so proud of what you have achieved here. And I congratulate you all for this. So I'm going to talk about, I suppose, I just in thinking about that, I purposely put the title on my slides today as Transforming Futures and Enhancing Lives. And it's really related to the event, not so much to me. I hopefully will contribute to that. But the actual event today, it's kind of like the culmination of a huge amount of work. But in actual fact, the work begins today because this is only the start. And it's amazing when, I don't know what the saying is, but you know, when all minds come together and people work together, great things can be achieved. So, let's see if I can manage this. No, that doesn't work. Okay. So what I'm going to talk about is people with intellectual disability in the Intellectual Disability Supplement to the Irish Longitudinal Study on Ageing. Big mouthful, IDS TILDA for short. And when we started off, we looked at the data about people ageing with an intellectual disability. And one of the papers we published was looking at the mortality rates. And what it showed us was that people with intellectual disability were dying on average about 20 years before the general population, which we thought was really, really shocking, particularly women. And there's something specific in relation to this, and we really needed to investigate that. So people with intellectual disability were dying on average at around age 54 in comparison to the general population at the age of 73. And that was back in 2015. And Ryan McConkie and his colleagues repeated that study in 2020, and they still identified people were dying earlier. And this is just not acceptable. We need to do something. And I think that's when we think about GRASP, think about the resources you have, and being really, really proactive in your health and in your ageing. This is what we're going to tackle. So my study is, what I've done is I worked with Professor Mary McCarran, and she is the PI, which is the principal investigator of IDS TILDA. Now IDS TILDA came about in about 2007, so it's over 15 years ago. And there's loads of longitudinal general studies throughout the world. This is the family. All the little coloured dots represent the longitudinal studies in the world. But Ireland is the only one that specifically looks at people with intellectual disability, which is very unique. We've got a really fabulous resource to really emphasise and investigate the health and wellbeing of people with intellectual disability. So we've done 5 waves of data collection, and a wave of data collection is every 3 years. And we've published all of these, and they're available on our website. But to take part in IDS TILDA, you had to be over the age of 40. We look at everyone of all levels of intellectual disability, living in all different circumstances. We send out pre-interview questionnaires. We do CAPI interviews, that's a face-to-face interview. We do objective measures. We do family care questionnaires as well. Now all of these encapsulate or capture the data for us. And the interviews, as I said, happen every 3 years. And we look at supporting as many people as we possibly can to be involved. We've got a very strong values framework under our study. And what we do is we offer different styles of interviews. So people can be supported, they can do the interview themselves, or if they want to dedicate somebody to do it on their behalf, they can have a proxy. Now the proxy must know the person really well, a minimum 6 months, but we prefer to have people who know them really well, like many years. Then we get the best data. So what are our objectives? Well, we want to understand the health characteristics of people with intellectual disability. We want to examine the service need and health service utilisation. We want to identify disparities in health. And I suppose my own background being health, I will focus very much on health today. but we've got lots of different areas that we cover. And we want to have a really robust reservoir of data so that we can share it with all of you, that all of you can come and use it, because this is your data. Everyone that has contributed, be they community members or support workers, you've contributed to the collection of this data. So I said we had a kind of a framework. Now, one of our frameworks is this scientific framework, and that's just all the different modules we cover when we ask questions. And within each module, then it drills down into different areas, and that's just an overview of it. We also do objective health measures. So that's one area that I actually am attached to, and I run this. So we look at doing objective measures, everything from neurological, psychological measures to things like measuring bone health, doing auditory assessments, doing oral health assessments. Now, throughout across the years, we started off with 753 people, which was represented about 10% of the population over the age of 40. Now, 40 is not getting old, but we have to go back a number of years so that we understand the trajectory, we understand as things progress. It's different in TILDA, the general population, they started at 50. Now, we chose 40 because, particularly within the intellectual disability cohort, a lot of people present with older age conditions at a much younger age. So I think, for example, people with Down syndrome and how they present with Alzheimer's dementia much younger. And then I talked about my values frame. So we're really strong believers that having people with intellectual disability within research is not just named on the proposal, they're actually embedded and part of it. So they do all sorts of things for us, from reviewing our questions. We have workshops, we have a focus and advocacy group, looking at our questionnaires, reviewing our questions and contributing right across from everything from inception to dissemination. People are involved. They're involved in the training of our field researchers. They're involved in how we administer questionnaires. We have an ambassador, and she's a research assistant who works with me in my office. And she's a person with lived experience of intellectual disability. So research is everybody's business. And including people with intellectual disability in research is absolutely imperative. So I'll give you some of our results. So we published our Wave 5 results only last week. And what we identified is that multiple morbidity, so that's the presence of 2 or more health conditions, is very high among people with intellectual disability at 72%. And you can see this is a comparison. So if you look at the navy and the lighter blue, this is a comparison between about 10 years ago and today. And you can see that lots of the conditions went down, but lots of them went up. And I'm just going to drill in a little bit into some of those. So when we compare our data, we compare it with TILDA, the general population, and the patterns of conditions are very different. So within the ID population, we've got gastrointestinal disease. So that's things like gastroreflux and constipation are very high. We've got mental health and neurological conditions are very high, and that's driven a lot by epilepsy particularly. Whereas that's not the picture in the general population. It's cardiovascular and respiratory disease. So that always kind of makes me think, when our government are doing health promotion, are they doing the right things for our population? So we have to keep these things in mind. So as I said, I was drilling down a little bit further and looking at the data. You can see that conditions are increasing, which could be attributed to age, but not everything is. Take, for example, constipation. Constipation is something that's amenable. We shouldn't see it. There's lots of things we can do to prevent it. But year on year, when we looked at constipation, it has been increasing. And I just have the figures up to Wave 4 here. So it went from 16% in Wave 1 up to 48% in Wave 4. That's a huge rise. And when we looked at that a little bit deeper, what we identified was that people with intellectual disability wasn't associated with ageing. It was associated more with the fact that they weren't out exercising. Diet plays a big part, but particularly level of intellectual disability. So if you think of somebody with more complex health needs, maybe more severe level of intellectual disability. So they're the types of things that can contribute. When we looked at the medication that people were on in relation to constipation, 42% of people were on laxatives, and of that 40% were on 2 or more laxatives. That's an awful lot of medication to be on for something that we can deal with through exercise, diet, good fluid intake. Yes, medications are needed in certain circumstances, but we need to be conscious and thinking about how exactly are we looking at the non-pharmacological stuff. And what we looked at when we looked at those pharmacological things is we looked at the burden of the medications. And one of the biggest burdens was the anticholinergic burden. And that comes with antipsychotic medication. And what that anticholinergic burden does is it impacts on our neuroreceptors. And it actually stops the action of a neuroreceptor called acetylcholine. And what acetylcholine does is it stimulates the bowel, it stimulates smooth muscle. So if we're on lots of medication that are actually causing us to, another action of these antipsychotics is it dries you up. So if you're dried up, well, that'll cause constipation as well. So there's lots of things working against us, but when we know this information, we know how to action against it. We look at oral health, and Professor Caoimhín McGill-Forick is my colleague he's a special care dentist. And in wave 5, 19% of people were edentulous. That means they had no teeth at all. 16% in the TILDA study. So there's not a huge big difference. But where the difference comes is when we look at restorative treatment. So that means people getting implants, people getting dentures and things like that. So 72% of people who were edentulous with an intellectual disability did not receive restorative treatment. And that compares to 5% in the general population. That's shocking. Those figures always shock me. But when we look at the oral health, what is it associated with? Well, if you've got poor oral health, you're twice as likely to have difficulty eating, which makes sense. You're twice as likely to be on a softened or a liquidized diet. Again, makes sense because if you've no teeth, you can't chew. But you're twice as likely to be constipated. So we're back to the constipation. So it's a difficult circumstance. I have to keep an eye on the time or I'll talk forever. What we looked at, when we did look at the oral health, is that 91% of people visited the dentist on an annual basis. That's wonderful. What are they doing? Because they're losing their teeth. We looked at 91% of people said they were brushing their teeth on a daily basis. Again, are they doing it well? So what we think is that home care is really ineffective. We really need to emphasise oral health in relation to the people we support. And one of the things that Kev has done is he's created a lovely resource online, which I think you could link to your grasp, called Brush My Teeth. And it is a lovely program that you can learn how to brush your teeth properly. You can learn how to brush somebody to support you to brush your teeth. There's lots of different ways, but this resource is available online. In relation to medications, as I said, people were on a lot of medications. So we look at regular medications, so 0 to 4 medications. That's called no polypharmacy. Polypharmacy is then 5 to 9 medications, and then 10 or more is hyper polypharmacy, which is needed at times. But I'll go to the hyper polypharmacy and the polypharmacy. We've a lot of people on a lot of medications. So in hyper polypharmacy, we had 33%. Now, some of that is required and is necessary because we have multiple complex health needs. But when we look at it in comparison to TILDA, so that's our general study, there's a huge difference, there's a big disparity, 72% versus 27%. The good news is that in wave 5, we have identified a decrease, particularly around those antipsychotic medications. And the largest decrease we saw was within the younger population. And what we're seeing emerging now after 15 years is that our younger population, so that's the 40 to 50-year-olds, are much healthier. they're living more independently and in the community than 40 to 50-year-olds 15 years ago who lived predominantly within institutional and residential services, which that's a really good milestone. But when we look at the medications, the most prominent medications still are antipsychotics, antiepileptics, and laxatives. So we can see the high levels of mental health issues, the high levels of epilepsy in comparison to the general population. But the picture is very different again, because in the general population, which is in this grey box, the most common medications are cardiovascular medications. Again, I think of health promotion and are we focusing on the appropriate health promotion for people with intellectual disability. My own area, as I said, is musculoskeletal health, and I look specifically at osteoporosis, which is quite an insidious condition, very often only recognised when somebody fractures. And people with intellectual disability have an increased burden because of lots of different ideas in relation to maybe a phenotype, which means people, for example, with Down syndrome, their bones don't mature fully, so they're at higher risk. Or they might be on specific medications. Antiepileptics are detrimental to bone health. They might be living in residential or services. I know when I worked in residential services, and I worked there many years ago, if there was a really hot sunny day, you'd cover people up and you'd have the sunscreen slapped on and whatever. Nobody got to see the sun because you were afraid that they'd get burnt. Unfortunately, we need, that was kind of the wrong thing to do. We do need some sunshine exposure. We need our vitamin D because that's made from our sunshine. But people living in institutional services and settings, generally speaking, don't get out and about as much to benefit from that. So when I looked at doctors' diagnosis of osteoporosis, in the first wave of IDS TILDA, we had 8% of people telling us. And by the time we got to the fourth wave and the fifth, the doctor's diagnosis was around 21%. It has dropped a little bit to around 19% in wave 5. So that was doctors' reported diagnosis. But what I did is I objectively measured. I used what they call a quantitative heel ultrasound, because not everybody can do a DEXA scan. Not everyone can get into a DEXA scan and lie still. And it's also kind of a scary machine. So I used this little foot machine that people could pop their foot in, and it measures your bone health in 10 seconds. And what I identified, that the people who did it, so 14% of the people who did it said they had a doctor's diagnosis of osteoporosis. But what I saw was that over 70% of people had poor bone health, either osteoporosis or osteopenia, which is kind of the precursor. And if you've got osteoporosis or osteopenia, you're at a higher risk of fracturing if you fall. And we all know as we get older, we're at a higher risk of falling. In wave 5, as I said, again, we objectively measured. And again, we're looking at around the 60% of people with poor bone health objectively measured, in comparison to about 19% of people who said they had a doctor's diagnosis. So there's big health disparities. One of the areas that I considered was in relation to risk factors. And there's this tool called FRAX used widely by GPs. But the risk factors on it are not applicable to what I have seen to our population. Like smoking and alcohol consumption was quite minimal, or corticosteroid use was quite minimal. People didn't know the parental history. So they're all the factors they look at to diagnose osteoporosis. Whereas what I was seeing was that 75% of people had gone through the menopause. 41% of people were on medications that would contribute to poor bone health. 34% had difficulty walking, and nearly 50% of people weren't drinking enough milk or taking in enough calcium in their diet. And taking it in your diet is the best way to take it. So overall, what I saw, that if you had difficulty walking, if you had a severe level of intellectual disability, or if you were on proton pump inhibitors, you were way more likely to have osteoporosis. So difficulty walking, 6 times more likely. Proton pump inhibitors, twice as likely. Now, proton pump inhibitors are for gastric reflux. And remember I said earlier on, the gastric conditions are rising. And what proton pump inhibitors do, you'll often see that the ads on the telly, neutralise your acid. Well, that means that the acid isn't strong enough to digest the food that you're eating to extract the calcium. So these are detrimental. And the unfortunate thing is, what's going on? The unfortunate thing is that we can buy these things over the counter. And if you're living independently and you feel your tummy is a little bit acidy, you can go down your chemist and say, I have a bit of an acidy tummy. You can be given those without a prescription. So these are the things we need to really be concerned about. The other thing I saw was that people, they were taking the medications, they had a history of fracture, and fracture begets fracture. So if you've had a fracture, you may get another one. Oh my God, okay, I'll be finishing up now. And also that there was no gender difference, and I think I need to kind of emphasize this, because a lot of the times osteoporosis is considered a female condition. And we had 6% of our men said they had osteoporosis, whereas I identified 90% of the men who did the quantitative heel ultrasound had osteoporosis. And some of the things that were driving that was the fact that they weren't active, the medications, the constipation again, and those proton pump inhibitors, those tummy medications. So I've actually published this and I can share that with you. But when we think about bone health and screening, people are not going for the DEXA scan. But what I can understand that, because it doesn't suit everybody. So what we need to think of is alternative methods. And I'm working now with a colleague of mine, and we're trying to develop an alternative method of screening that will be accepted by consultants, because a lot of the times consultants won't accept anything but a DEXA. And then I'll finish off here by saying our vitamin D is very low as well, and we need to be on supplementation. So people, to kind of approach your bone health, you really need that multifactorial approach. You need to be looking at our screening. We need to be looking at the risks that are specific to people with intellectual disability, but we need to be challenging it by doing our exercise, looking at our diet, and really increasing education and awareness. So thank you so much. I just highlight 2 little programs that I've done in translation. One is PPALS, and that's physical activity for people with intellectual disability, and the Get Wise program that Orla talked about earlier on. I do have an online MOOC that people can engage in, and I will leave it at that because I could talk